Hello, and thank you for joining us on this webinar today. Prompt diagnosis of infectious disease is brought to you by VisualDx. I'm Annie Sullivan, and I will be today's webinar moderator. Dr. Noah Kraft will be presenting the webinar today. Dr. Kraft attended UCLA for his MD and PhD degrees and completed the Diploma in Tropical Medicine and Hygiene at the London School of Hygiene and Tropical Medicine. He did his dermatology residency at UCLA as well, and is now a practicing dermatologist in Los Angeles. He has published more than 15 chapters, 45 peer-reviewed manuscripts, and is the senior editor of a popular dermatology textbook. Dr. Kraft has been a leader of several local and statewide teledermatology programs in California. He is currently the Chief Medical Officer of VisualDx. Please now direct your attention to Dr. Noah Kraft.
So thank you all for joining. It's a pleasure to present this webinar about infectious disease. As Annie mentioned, I have an interest in tropical dermatology and tropical medicine, so this is one of my favorite subjects to talk about. I'll be presenting for about 20 to 25 minutes, and then we'll take some questions. Feel free to type in any questions as we go along. Just by way of disclosure, I don't have any relationships with the pharmaceutical industry, and the Chief Medical Officer for Logical Images. My background, as Annie mentioned, is in microbiology and immunology. I've studied around the world in Brazil, in London, and I teach in Mozambique, Brazil, and Colombia. Most of what you're going to hear about today, though, are diseases that are really important to you in your practices around the U.S. So not tropical medicine, but infectious and contagious diseases from around the U.S. And most of what I'm going to talk to you today about is diagnosis. I'll mention a little bit about some important things related to the treatment of these diseases, but I thought I'd start off with a little bit of humor. Most people think about dermatology in terms of wrinkles and Botox, but we're really going to talk about some important infectious diseases of the skin, and these cartoons highlight just how dermatology can fix the world with Botox, but interestingly, Botox actually comes from an infectious disease, a very important one, botulinum or botulism. So let's start off with this slide, and I know this is not a two-way street right now. Eventually, we'll have this be an interactive forum, but I'm going to show a lot of images, and when you see the images, I want you to think, what is the diagnosis? What more do I want to know from this patient? How could I make that diagnosis? So in this case, if you were going down the wedding reception line and your Uncle Kevin stuck out his hand and said, you know, how are you? And you saw this, would you touch it or would you not? So that's the question. Is this an infectious disease? And so we're going to go through some variant presentations of infectious diseases and some things that are infectious and others that aren't. One of the important things is that a lot of times in dermatology, especially, people feel like they're treated like they're infectious and they're really not. So this patient I'm showing you here, this is a simple case of destructive psoriasis, so not infectious. And what about this case? Erythematous scaling plaques of the elbow. So this is a textbook case of psoriasis. And this is a patient that I would recommend actually touching the skin and making the patient feel normal, because most patients, most doctors and most people in this patient's life will treat them as if they're a leper or if they're contagious. So this is regular old psoriasis at the elbows. So here's your first quiz. Excuse me. Which one of these two cases is contagious? So on the left is a young man, 20-year-old man, and on the right is a young child, probably about 4 or 5 years old. So which one of these two cases is contagious? When you look at them, they're both annular scaling plaques with the erythematous rim. So the answer is the patient on the right, but you can see how similar these two patients look. And so it's very hard to tell these two diseases apart. So let's start talking about Tinea corporis, which is the case on the right. I'm going to show you a lot of different variant examples of Tinea corporis. So this is the classic multiple concentric rings presentation of Tinea corporis in an adult. And you can see that in some cases it can get very aggressive. And in the lower right, you can see that it actually spreads right across divisions in the skin, so right across the arm, pays no attention to skin boundaries, quite contagious. In pigmented skin, it's important to know that it's often hard to see erythema, so you can barely see the rim of erythema in this tinea corporis of the shoulder here. And sometimes the erythema is very faint. So in this patient, you can see that the rash has been here for several months, and you can see that the leading edge of this spreading plaque is actually winding around the whole upper trunk like this. So don't get fooled that tinea corporis can be a widespread disease. And here's some other classic examples of tinea corporis. Concentric rings with scale. Again, a leading arcuate or annular presentation. Sometimes it can be quite widespread, so especially in children with a pet that has one of these species, they can acquire the rash in multiple areas simultaneously, as in this case. The diagnosis can be made in the office very simply by doing a skin scraping and putting on 10 or 20% potassium hydroxide, and that's what I'm showing you here. So you can see these long hyphae that have a kind of a refringent or birefringent characteristic that's greenish blue. So easy to make the diagnosis. So here's another quiz, an A-B quiz. Which of these two diseases is contagious? So this is a tough one. So you have circular or annular scaling plaques, and then here you have round erythematous plaques with very little scale. And the answer to this one is again on the left. So this is tinea corporis, kind of a variant presentation with very little scale, and again this is psoriasis over on the right. So just to recap, tinea corporis is contagious. It's kind of in the mild to moderate contagious category. So you acquire it by wrestling or rubbing up against someone who has it or pets that have it. The therapy is quite simple. If it's a localized process, you can use topical azoles such as clotrimazole, ketoconazole, econazole. And for extensive disease, often you need to use oral antifungals such as terbinafine daily, especially if it involves the hands or the face. And so just to wrap up and burn one image of tinea corporis into your mind, this is a classic concentric rings, scale, sometimes even pustules on the extensors or trunk. Okay, let's move on to a second disease. So another A-B quiz. Which of these is contagious? So very hard to tell apart. So both of these patients presented saying, "Doc, I was bitten by a spider." And I'm sure everyone on the call has had a family member or patient, probably in the last week, that said, "Doc, I was bitten by a spider." And so they present like this. And I would say about 99% of the time when someone says, "I was bitten by a spider," it's actually a presentation of community-acquired or community-associated MRSA. So this patient on the right, this is an MRSA furuncle or abscess, and over here, this is a true brown recluse spider bite. So you can see there's quite a bit of necrosis going on underneath, and soon that necrosis will spread. But this is a true spider bite. This is an MRSA abscess. Very difficult to tell apart, but the truth is that most patients never see the spider and are not actually bitten by spiders. So let's go through some of the presentations of community-associated MRSA, a really common problem. In our hospital in Los Angeles, it's about a 60% prevalence rate, so really a big problem in the world. This is an MRSA pustule, and most cases of MRSA will actually have some purulence or pus associated with it. So here you can see a central pustule, but a fair amount of erythema and induration around it. Here's a case of multiple MRSA pustules. And these will tend to be recurrent on the buttocks in patients who are carriers of MRSA. As pustules or furuncles progress, you can see that they can have even more underlying pus formation, and so this is a true furuncle and really wide erythema around it. When you have multiple furuncles coalescing into a big plaque, we call that a carbuncle. So here's one example of a carbuncle. Here's another example when it starts to ulcerate of another MRSA carbuncle. And then as the lesions start to progress into necrosis or an eschar, we call that ecthyma. So MRSA ecthyma is a deep-seated MRSA infection. You can see the pus pockets around it here. This is to be kept separate in your mind from ecthyma gangrenosum, which is caused by Pseudomonas. And so then once it progresses to true eschar, we call that an ecthyma. So these are deep-seated MRSA ulcers caused by a deeper infection. So just to recap, MRSA, highly contagious. One thing to keep in mind is that the prevalence in the community is really high. So in your average healthy person, you can find carriage of MRSA sometimes up to 30% of the population. How many people get the disease, it's really hard to predict who's going to get the disease. So carriage of the disease is common, but the actual presentation of MRSA complications such as impetigo, furuncle, abscess, and all the other things that I showed you is pretty low. One fine point is that with bland cellulitis, so non-purulent cellulitis, we've done studies of this, and most cases of cellulitis are still caused by methicillin-sensitive Staph aureus. And so unless you have pus or purulence with the presentation of cellulitis, it's most likely to be a staph species that's sensitive to penicillin or to methicillin. Another note to that is that now, compared to decades ago, the prevalence of staph causing cellulitis is actually higher than those strep species causing cellulitis. So it's probably about a 70-30 ratio of staph and strep when it comes to non-purulent cellulitis. If there's a cellulitis with pus or purulence, for sure, you should cover for MRSA. The therapy for MRSA depends on the aggression of the disease. So for localized disease like impetigo, you can use mupirocin ointment, which is quite effective against MRSA. And then for deeper infections such as an abscess, IND is really the treatment of choice. There have been studies done demonstrating that IND alone is sufficient to treat an abscess. However, most people will do an IND and they'll treat with oral or intravenous antibiotics depending on the state of the patient. So for extensive disease, it depends on your sensitivities. Most people will use doxycycline or trimethoprim sulfamethoxazole with amoxicillin or clindamycin, or in advanced cases, inpatient, you can use vancomycin or some of the more the newer agents, linezolid or daptomycin. Okay, so another quiz, AB, which of these is contagious? So again, very hard to tell. You can see I'm not taking it easy on you, showing you presentations that look almost identical, but the reason I'm showing you these is that these are really common misdiagnoses. So on the left, you have MRSA abscess, and on the right, this is a case of paniculitis. So it's really important to know the differential of tender erythematous plaques. And just to wrap up, to burn an image of MRSA into your mind, closing up this subject is a fluctuant erythematous tender nodule with a central pus. That's an MRSA abscess. Okay, next subject. So AB, which of these is contagious? So this is a tricky one. But just think in your mind, what am I looking at? So you're looking at petechiae or purpura of the ankles in both these cases. So these would not blanch in both cases. And this is a tough one. On the left, the patient's quite ill, and on the right, the patient's not very ill at all. What you're looking at is a case of meningococcemia on the left and leukocytoclastic vasculitis in the early stages on the right. So here are some other cases of meningococcemia. You see that dusky hue. When you see that dusky purple non-blanching macule, really red flags should be going off in your mind. And this particular presentation is near and dear to our hearts out here in LA, and in New York there's been a resurgence of meningococcemia in some of the communities here, and as a deadly disease, it's commonly missed and needs to be detected and treated very early. So here are some more advanced cases in the context of DIC, or disseminated intravascular coagulation. Again, advanced to gangrene. So meningococcemia, very deadly disease. This is a classic presentation. Again, these purpuric macules or non-blanching purpura occasionally presents with pustules centrally. And so meningococcemia, again, a very contagious disease. In this case, meningococcemia spreads usually by respiratory droplets. There are recent outbreaks this past spring in men in Los Angeles and New York. Complications, of course, the morbidity in uncomplicated meningococcemia is 10%, and in the presence of DIC is upwards of 90%. The therapy needs to be given very early, the ceftriaxone or cefotaxime if you're not sure of the susceptibility, and then penicillin if you're sure of the susceptibility. Okay, switching topics. So this is going to be now an eight case quiz. I'm going to go through these very quickly. So just think in your mind, what is the most likely diagnosis, and then what is the differential diagnosis? So these are erythematous papules on the wrists of a young child, erythematous papules, crusted papules, and you see over here pustules on the hands of a child. Case 3, erythematous nodules in the axilla of an adult. You can see a biopsy was performed. Diaper distribution, erythematous plaques in an infant. Erythematous nodules on the shaft of the penis in an adult. Crusted diffuse plaques on the lower extremities of a hospital-bound patient. And this is the primary lesion of all of those last patients I just showed you, a linear erythematous, I guess, macule or papule on the side of the hand. And this is the causative agent in all those last 7 cases. This is a mite, and this is a female mite. You can see the egg inside of her. So this is a scabies mite. So the answers to the last 8 slides are scabies. Why am I showing you these cases? Because when a dermatologist sees all these cases, a red flag goes off for scabies, 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 scabies. But some of these presentations are not the usual presentation for doctors in primary care. And it's important to recognize these because some of these are really classic presentations. So just to give you one more quiz, an A-B quiz to compare, which of these 2 cases is contagious? So a pustule on the finger with some surrounding erythema, or grouped, or not grouped, but coalescing vesicles in the finger webs on the right. And the answer is, on the right, this is a presentation, on the left is a presentation of scabies. On the right, this is a common presentation of deep-seated vesicles of dyshydrotic eczema or Pons Lox. So I'm going to show you a few of the classic and variant presentation of scabies just to refresh your memory. One of the important things is that when someone has scabies, usually if they're an immunocompetent person, they just have a few mites in the burrows on the hands, around the nipples, axilla, or genitals. And all of this eczematous-like reaction around the rest of the body is an allergic reaction we call an id reaction, or autoeczematization. And so if you're thinking of where are the mites on this patient, up here on the arms, you're not going to find any mites. Really, you're just going to find mites burrowed into the finger webs, around the nipples, in areas where the temperature is just perfect for the mites. And so when I'm showing you pictures like this is another patient who has scabies. These papules up here on the arm, these are not going to have mites in them. So this is the autoeczematization reaction. This is where you're going to find the mites, in these pustules and in these burrows around the finger web. So you can see all these pustules around the hand of a child. An exception is in nodular scabies. Each of these nodules around the groin will have one or a whole family of scabies mites in it. And so in this type of presentation, especially in the genitals, this is where families live, and this patient will be very, very itchy all over their body, but the scabies themselves are living in the scrotum and around the buttocks here. This is another example of nodular scabies. So recall in your mind that picture of erythematous nodules on the penis I showed you during the quiz, and this presentation in a dermatologist's office is scabies until proven otherwise. So in an otherwise healthy patient with erythematous nodules in the groin or buttocks, that should be scabies until proven otherwise. It's a really important take-home message. And this is where you should scrape. So I realize that most offices don't have microscopes in the office anymore, thanks to CLIA, but it's a very easy diagnosis to detect. And so this is the path of a mite. And on one end or the other, the mite will be. It's sometimes hard to see it, but in this case, you can see a very small gray dot at the end of this burrow, and that's the mite. So you can very easily pick that out and put it on a slide and check. This is a younger scabies mite. This is pathognomonic diagnostic as well. This is scabies poop under the microscope. So when you see these brown pellets, even if you don't find a mite, that's diagnostic of scabies. And here, unfortunately, I can't show you this video over the web, but this is a video I took of a baby hatchling scabies. So I watched this baby being born from his or her egg just prior to this video being taken. So the first scabies birth ever captured on film, I believe. So scabies take-home message is there are hundreds of lesions but very few mites. So most of the rash you see with scabies is really just an eczema-like reaction. The burrow is found down on the finger webs, around the breast or axilla and groin. If you can do the scraping in your office. Scabies, most of you know, it's very intensely itchy and it's almost always worse at night. It's very contagious, but not quite as contagious as you might think. So if you ask dermatologists, we probably see a scabies patient on average once every other day, and we shake their hands. And in 10 years of practice, I've never caught scabies. I don't know any dermatologists that have. So just shaking hands, it's pretty hard to catch scabies. The way that you catch it is usually from hugging or living with someone. Nursing homes, it's nurses that will spread it from patient to patient by changing the bed linen. So it's a bit hard to catch scabies indeed. There's some variants of scabies I wanted to touch on briefly, and that's crusted scabies, formerly known as Norwegian scabies. And this example I'm showing you here, this is a patient in a nursing home or long-term care facility. You can see there's this characteristic yellowish waxy scale. And these are patients, they tend to not be as itchy as you might think. They are absolutely covered with mites. Here's an example where if you scraped this hand, you would scrape off hundreds and hundreds of mites per centimeter. And so all of this is a big community of scabies mites. So this yellowish, waxy, scaly plaques on the hands and feet especially. Here's an example of a patient that's had crusted scabies for several weeks or months, and you can see the skin just thickening up. If you take a biopsy through that, it's basically like a skyscraper hotel full of scabies. So many, many, many mites. Again, this yellowish, waxy scale, and this is very characteristic of crusted scabies. And I see Annie's posting a note. If you want to ask questions, we're coming down the home stretch here, so any questions I'll take, feel free to post them in the chat or post them on Twitter with hashtag VisualDx. So just to wrap up, scabies is contagious, but not as contagious as you might think. Just a fine point about the global burden of scabies. So scabies and ectoparasites are some of the most important diseases around the world. In some communities, there's a prevalence rate. So that's the number of patients that actively have it, upwards of 50%. So some communities in Africa, more than half of patients have scabies at any one time. It's a very important disease, leads to really important loss of work and productivity because of the itching. The most important complications is recurrence. There are some cases of permethrin resistance and ivermectin resistance cases in the U.S. So occasionally you'll find that when you treat these patients, they don't get better. You may need to treat them 2 or 3 times, and occasionally, it's very rare, you might need to treat them with 2 agents simultaneously, such as ivermectin and permethrin. As far as I know, as of last year, there were no documented cases of scabies that were both ivermectin and permethrin resistant in the same mites, but I'm sure that's coming soon, so that won't be fun. And one fine point about scabies is that often when people are itchy, people think, every bug is scabies, but there's a resurgence of head lice and body lice in our community here in Los Angeles. This is very common no matter where you are, whether it's Beverly Hills or Africa. This is a patient in Los Angeles in our hospital, and you can see this rash around his neck. The patient was obviously quite sick, but he came in, he's a homeless patient, and you can see these nits in his clothing. This is the classic presentation of head lice rash, so that the lice, they live in your hair, but they feed on your blood, and so you'll get these erythematous papules around the neck. And head lice are highly contagious. So I just wanted to show you those few slides of the classic presentations of head lice. you'll often find the nits in the hair and on the clothing, especially in homeless populations, but school children pass this around like hotcakes. And so just coming down the final stretch here, now final A-B quizzing. So which of these two patients is contagious? So you go over to your boyfriend's house at night and you see this rash on his face. Which of these would you be okay kissing and which would you not? So that's the question. And in this case, it's a trick question. So these are both contagious. So on the left, you have herpes, and on the right, you have impetigo, both contagious. So in this case, hold off. Don't kiss your boyfriend that night. Give it a week. And so the next section we're going to talk about is about herpes simplex. And what I want to show you is really the classic presentation. So what we're looking here is grouped vesicles, erosions, and pustules on an erythematous base. And I'm showing you this picture because most people think of herpes or cold sores as around the lips or around the genitals in the case of genital ulcers. But look at how far away this case is from the lips. So this is the same exact virus, the same exact process coming out of nerve ending, but showing up outside on the cheek. This is still HSV1 in this case. And this is another example of the classic presentation, so group pustules or group vesicles, erythematous base. You'll notice I'm showing you again, there are no lips and no genitals anywhere near this. So this is herpes simplex, but not on the genitals. So when it comes to herpes, unlike your home or office where it's location, 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 with HSV, it's morphology, morphology, morphology. So if you see this presentation, grouped vesicles, grouped pustules, erythematous base, it doesn't matter where on the body it is, you've got to be thinking a herpes infection. So the presentation of the vesicles can progress to hemorrhage or purpura, as you see in this case at herpetic Whitlow on the palms. Again, grouped vesicles, pustules here on the wrists, I think. Again, herpetic Whitlow on the hands, so grouped vesicles with some hemorrhage. Pustules and vesicles on the finger. Again, this is herpes Whitlow or herpetic Whitlow. And here's a case of HSV2, really far away from the gluteal cleft here. So herpes still presents painful. Often these cases are recurrent, so they're going to come and go and come and go. So morphology 101, herpes simplex. Look for that morphology. It doesn't matter where it is on the body. So grouped vesicles, pustules, or punched out erosions on the erythematous base. So HSV, how contagious is it? It's quite contagious. And it's usually spread by direct contact. One important point, so I'm getting a little feedback, but one important point is that it's believed that most people have been exposed, especially to HSV1. So if you measure the IgG levels in adults past the college age, you'll find IgG to HSV1 in about 80% of patients and HSV2 in 20%. So most people have been exposed or in a carrier state, and there's some controversy still as to whether you can transmit the virus during the carrier state without an outbreak. I'm not going to go into it too much, but it's important for you to know that because your patients are usually going to ask about it. So recurrence is one of the biggest complications, and the therapy for herpes is either acyclovir or valacyclovir, and you should know about prophylaxis and resistance to these drugs. So in some cases, especially in immunocompromised patients, you can have resistance to acyclovir or valacyclovir. Then there are agents like foscarnet and ganciclovir you may have to use. So I think I'll stop there, and thank you all for your time and attention, and we can take any questions that you might have. And of course, if you're interested, please feel free to email me or call me directly. That's my cell phone if you have any questions. First question, what other diseases can present like meningococcemia? So that's a great question. So the question, what other disease can present like meningococcemia? There's some layers to that, but I assume the question is about the idea of purpura or vasculitis-like lesions. So maybe what I'll do is I'll use VisualDx to show you the differential. So this is the homepage of VisualDx. Probably all of you have seen this. since you're logging onto this webinar. So if you're looking for the differential of Purpura in a patient with a fever, I might start here. So a patient, an adult with fever and a rash, and the classic presentation of meningococcemia would be either Purpura or petechiae. And so here's a really good differential diagnosis for the presentation of meningococcemia. You can see meningococcemia is over here. You might, to refine this, if you look at toxic patients only, here's the 18 different diseases that present with Purpura and a toxic-looking patient. And so probably some of the most important things are ranked by these emergencies. So these emergency cases, I'm ranking to the top now. You have acute meningococcemia. Rocky Mountain spotted fever often has the petechiae as well. And then some of the autoimmune diseases such as vasculitis, CTP, can present this way as well. So this is a pretty good differential for the Purpura associated with meningococcemia. You can always add in other findings like pustules, and you can see now other diseases such as sepsis get ranked up there with acute meningococcemia. The second question is, what is the proper way to test for herpes? So this is a great question, and this has changed over the years. And so the question is around the idea, if you have a patient you're considering herpes, what test should you do? And often people, their first instinct is to reach for a blood test and check for an IgG or IgM. And this is absolutely not a good way to test for herpes. That will tell if you've ever been exposed to herpes, but if you want to know what that testicle is, the best test to do is a direct fluorescence antigen, or DFA. And the way that you do that is to unroof the vesicle and then just scrape a little bit of the bottom of the vesicle and put it on a glass slide that's appropriate for a DFA. Most of your hospital labs or outpatient labs will supply these slides to you. And in my hospital, it's a 4-hour test, so you get an answer within 4 hours. It's the most sensitive and specific for HSV1, HSV2, and varicella disease. A second best test would be a viral culture. So you can take that same fluid and send it for a viral culture. It's important to have the right media and to have it refrigerated, but that's the second best test for herpes. So in order of importance, it's a direct fluorescence antigen, then a viral culture. I suppose you could do a biopsy, but that would be a bad plan. And then lastly, ultimate last would be a blood test for IgM, but that really does not tell you much about the patient's lesion itself.
Noah, this is Annie. Are you able to hear me?
I can hear you, sure.
Okay, we have another question. Have you seen multiple HSV lesions that will coalesce into one large lesion or ulcer without raised borders?
I've seen multiple HSV lesions coalescing. I would say the answer is yes. So aggressive HSV, so that, let me see if I can show you an example of that. I do HSV and show you this disease, but show you the disease in an immunocompromised patient. So in an immunocompromised host, you can get really aggressive presentations such as this. So here you have HSV that's just running amok over the skin. So this is coalescing groups of HSV in an immunocompromised patient. And another common area that happens is persistent or chronic HSV of the genitals. So here you can see these punched out coalesced erosions. And this is all chronic HSV in an immunocompromised host. So if you do see an aggressive case like that, you might want to consider, here's some other really aggressive examples in an immunocompromised host. You might want to consider an HIV test right out of the gate because this kind of unchecked presentation of HSV is much more common in the absence of a good immune system. I hope that answers the question. The other way to think about it, though, is varicella zoster or or herpes zoster in the shingles type presentation, that can have a more protracted presentation, and so often it would start as just one or two vesicles or groups and then coalesce to larger plaques. And so let's see if I can show you an example of that as well. So here you see, if you're not quite sure if you're looking at herpes simplex, you can see how the vesicles of herpes zoster can really start to coalesce into these large plaques that will eventually erode as well. So that's one thing to just make sure you're looking at herpes simplex or zoster. There's this occurrence that happens, I've seen it happen many, many times, where a patient will come in and say, yeah, they get shingles every year. So that's just not happening. So usually if someone says they have recurrence of shingles, it's because they're having a recurrence of herpes simplex, not in the traditional areas like the lips or genitals. And so you can see how aggressive zoster can be, but it's very, very rare for zoster to be recurrent over and over again. If that answers the question.
Great. And we have time for about one more question. Which patient population should receive prophylaxis for HSV1? And how often should they take the prophylaxis?
So the question is around prophylaxis for HSV1. And I would say the extension of that question is HSV1 or 2. You really can't tell from the presentation which of the simplex viruses it is. If it's orofacial herpes, it's about an 80% chance, it's 80 to 90% chance it's HSV1. And if it's genital, it's about an 80 to 90% chance it's HSV2. But the virus can infect both sites. So it doesn't matter to me if it's HSV1 or 2. The question in my mind is, how badly does it disrupt the patient's life? And most of the guidance would say that if a patient gets 6 or more eruptions per year, then they're worthy of prophylaxis for either HSV1 or 2. In my mind, if a patient has 2 outbreaks a year, but they're really disruptive, or they're in the public stage and it ruins their life, well, that's enough for me to put them on it. It's a very personal decision. The medications for prophylaxis are exceedingly safe, so acyclovir or valacyclovir. And so if you get bad cold sores or bad genital herpes, and you're getting more than 1 or 2 outbreaks a year, I think it's up to the patient and the doctor to decide together about prophylaxis. It's extremely safe and quite effective. So I tend to use it more than the guidelines, which say over 6 times per year, because patients tend to really hate getting these outbreaks. And if there was a higher risk for the medication, I would say you could be more stringent. But most young, healthy people, in the absence of renal problems, I would say it's okay to use it as requested.
Thanks, Dr. Kraft. I think that's all the time that we have today for questions, but if anyone has any other questions, please email asullivan@logicalimages.com. This recording will be made available for you on YouTube, the VisualDx YouTube channel, within a couple days, so check back for that, and thanks so much for joining today.